Bismillah ar-Rahman ar-Rahim. Welcome everyone in this new meeting of Egyptian Society of Nephrology and Transplantation. Tonight we have a very specific meeting, clinical pathology, starting a series of glomerulonephritis, and we'll start by FSGS. Our idea is that we are all faced with a nephrotic syndrome case and a renal biopsy that says it is FSGS. When we are faced with this, many questions come to our mind, include how can we use the biopsy to interpret the etiology, which is very important regarding the prognosis, regarding recurrence, regarding the effect of treatment. How can we interpret this biopsy in the form how to treat, to initiate treatment, and comes to the important point, how to treat, when to initiate treatment, how to initiate treatment, which drug to use, when to stop treatment, when to intensify treatment, how can we judge, many how, what, when we are faced with such a biopsy saying that is FSGS. So in this specific meeting, for the first time, we have two distinguished speakers. For our first time in this season to have two speakers at the same time. We have Professor Ahmed ELkerei, who is the professor of nephrology, renal transplantation and medicine in Alexandria University. Professor ELkerei was responsible for the Clinical Nephrology Day in NephroAlex last month, which was very, very successful and with its highly selected and rich topics. And Professor Wesam Ismaiel, Associate Professor of Pathology at Prince William University. She is the chair now of ISN Renal Pathology Group, and let us congratulate her for this new position, which we are all proud with. And it is considered one of the out of proud to Egypt as to catch this position in the International Society of Nephrology. Hope you next coming to be the ISN president, like Professor Wiening, for example, in the past. In this specific meeting, we will proceed in case scenario 4 to see what we are doing and what to do clinically in a clinical form, not in a simply in a lecture form or in the usual form. And so we will open discussions in between cases, and if needed in interactions during the cases, and if needed during the cases, we can catch some questions and stop speakers to make it as much as interactive as we can. I suspect to be a very, 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 very successful meeting, and let we proceed. We will start by the first case, Professor Ahmed.
السلام عليكم ورحمة الله وبركاته.
وعليكم السلام ورحمة الله وبركاته. أهلا وسهلا.
بسم الله والحمد لله والصلاة والسلام على رسول الله صلى الله عليه وسلم وأشهد أن لا إله إلا الله وحده لا شريك له وأشهد أن محمدا عبد الله ورسوله. شكرا دكتور ياسر على ال very nice introduction. I'm really honored to be in this prestigious ever meeting, and we should all remember Dr. Hussein Shaisha each time we come here to his and انتفعوا بإذن الله. Signed by Prof through the glomerulonephritis as a series of clinical pathological cases, as we've been doing in the ESNT annual meeting for years with the guidance of Professor Ayman al-Rifai. We figured out that going into the specific points of FSGS as case-by-case scenario, just to point out to these points, whether the classification or the pathogenesis or the treatment or the prognosis or the recurrence or whatever, are real life scenarios. They are not just theoretical points to be memorized. No, they are real life scenarios. So let's go all together in FSGS and try to go deeper inside. First, we should know that it's now considered the most common glomerular cause, glomerular lesion causing end-stage kidney disease. I'm not saying that FSGS is the most common glomerulonephritis, but it is the most common one that leads to end-stage kidney disease. And the very important point, which I would give Wesam the chance to start with, that this lesion is actually just a histological pattern and it is not a specific disease entity. I mean, you cannot say that FSGS is just like minimal change disease. It's a disease that you can tell what to do once you diagnosed it. It is not. It is just a histopathological pattern of injury in the glomerulus. Wesam, do you agree with that?
Yes, of course, Ahmed. Very right. It's just it's considered a clinical pathological entity. This is one of the excellent examples of what we mean by just a pattern of glomerular injury, rather as you mentioned in your slides, rather than a specific disease entity.
Okay. At this point, would you give us a glimpse about the histology of this type, the pathological pattern? What is this pathological pattern, and what actually is the meaning of FSGS and the other terminologies that are going around with the same or nearby words? Would I stop screen sharing and
yes,
you start yours?
Sharing, please. Yes, please.
Okay. Okay. I stopped my sharing.
Yeah.
Okay, as Dr. Ahmed mentioned, focused segmental glomerulosclerosis actually means that we have obliteration of the capillary lumen by increased extracellular matrix. So this is a normal, more or less a normal glomerulus, but then there is this slight area on the right. I know you cannot see the arrows, but you can see that there is this small obliteration of the capillary tufts here. And this is what we consider FSGS. Segmental means it involves only one part of the glomerulus. It could be, however, it could be with or without full cells or foamy histiocytes. And to find overlying epithelial cell hyperplasia is common, as you see. So this is not a crescent, and it's not an finding, and it does not, it just this signals that we have a problem with the podocytes and that we do have later epithelial cell hyperplasia. Segmental sclerotic lesions has only a small volume, usually only 12% of the entire glomerular volume, and hence can be easily missed on a single section. This is why we require a lot of serial sections on the biopsies in order to be able to visualize FSGS. The important point that this is not always sclerosis. It can be proliferation. You can find cellularity, and you don't have to find actual sclerosis of the glomerulus to call it FSGS. The word focal denotes that we have a heterogeneous involvement. So focal means that it involves less than 50% of the glomeruli, usually early in the disease, because later on, advanced FSGS, it involves more than this, so it's not more. But early in the disease, as per the disease description, it's focal, so it involves only less than 50%. And segmental means, you can see in this picture, only part of the glomerulus is involved, the lower half of the glomerulus. Serial morphologic analysis, as I said, in the various forms of FSGS shows actually the sclerotic lesions involve the great majority of the glomeruli. As I mentioned, FSGS is not really as focal as its name implies, and this is why it's very important to sample a proper number of glomeruli when you are looking for FSGS. We've discussed before that a definition of an adequate biopsy is from 8 to 10 glomeruli, but when the disease in consideration is FSGS, this number is never enough, because as I said, it requires a lot of serials. We need to go deeper, and sometimes if it involves less than 10% of the glomeruli, it's going to be missed. However, how many glomeruli need to be present in the biopsy? How many sections do we need to examine? We have only little evidence of how many glomeruli we need. We know that we need at least more than 10, 15 to 20 in order to be more or less confident that we don't have FSGS in this biopsy. The early FSGS lesions are very focal and are juxtamedullary. So if we don't have a corticomedullary core, then again, it could be missed. And as I said, these diagnostic lesions could be missed by artifacts. The affected glomerulus is not present in the section, with segmental lesions is not present in the plane of the section. This is a bit of physics. We need 3D morphometry. So this is why we do a lot of sections and a lot of serials in order to, at the end of the day, to visualize the whole segmental lesion and be able to with FSGS. Diagnosis, it's not always a straightforward diagnosis, and it's not always that easy to find this lesion. FSGS, as I mentioned, is a clinical pathological entity. The etiologies are, as you go hear from Professor Ahmed, are diverse and multiple. Morphology can, to some extent, sometimes reflect the etiology and gives you an idea about the prognosis. This is the podocytes, and you have here podocyte effacement. However, this is what FSGS looks like in the EM. You have a collapsed glomerulus, which started to sclerose, and you have loss of podocytes. Morphological classification of FSGS, which was done by the Columbia classification, classifies FSGS into 5 variants. FSGS NOS or not otherwise specified, meaning that this type of morphology does not fit into the other 4 types. So NOS means that it does not have a classic perihilar, a collapsing, or tip, or cellular. So when we use NOS, simply it means that there is no specific morphology there. It could have been a collapsing variant and turned into an NOS, or what we call a classic variant. It could have been tip, but then it's not, again, it's not tip, it's more advanced sclerosis, and now what we have is an NOS, and so on. And it could have been a cellular variant. So these are the variants. Again, we agreed that this is mainly a segmental lesion. So this is what we call perihilar. It's close to the hilum of the glomerulus, and this is one of the most difficult types actually to diagnose. And its morphological or its clinical morphological significance is debatable. It's a common type, and in order to classify biopsy as perihilar, we need more than 50% of the glomeruli in the biopsy to have this type. If more than 50% of the glomeruli showing segmental sclerosis is perihilar, then it's perihilar. On the other hand, the other variants where you have tip lesion means it's directly adjacent to the hilum, involving the tubular pole of the glomerulus. And this means that you have to visualize in the same section the hilum, the arteriole, as in order to classify this as tip. Again, a lot of serials and a lot of sections in order to be able to visualize this as a tip variant. To get a set where you can see the hilum and the FSGS. And if you have a single glomerulus in the biopsy with a tip lesion, then this is a tip variant. You don't need the number of glomeruli which are needed for the perihilar variant. The same is for collapsing. Collapsing variant involves no sclerosis. You have a tuft collapse with a significant overlying epithelial cell hyperplasia. And again, a single glomerulus is enough for diagnosis. And then we have the cellular variant. This is the least common variant. Definition varies between that you have inflammatory cells, carrier excess, nuclear dust, and so on, or whether it's mainly histiocytic infiltrate. And again, a single glomerulus is enough for establishing the diagnosis. This is the perihilar variant. Usually in perihilar variants, you get a lot of sclerosis and hyalinosis, and the non-sclerosed glomeruli are typically enlarged, what we call glomerulomegaly, since this type reflects an adaptive response. And as you're going to hear later, these patients usually present with subnephrotic proteinuria. This is the TIP variant, and in TIP variant, you can get what we call herniation of the glomerulus into the tubular pole. As you can see here, the glomerulus is entering into the tubule, and this is what we call herniation. This is not enough to diagnose a TIP variant, but it's enough to alert you that you might have a TIP variant in the biopsy. And this is what we call a TIP variant, and we're going to show you later. This is one of the benign forms of FSGS with a good prognosis. Then we have the collapsing variant, and as you can see, you can either have a global tuft collapse or, again here, a global tuft collapse with a lot of podocyte hyperplasia. This is the silver stain. This black stain is the silver stain. Again, you do not see the inflated capillary loops. All what you see are the collapsed tufts. They are seriously collapsed, and you have a lot of epithelial cell hyperplasia. All of these pink things you see are the absorption droplets, which are present in within the podocyte hyperplasia. And then finally, the cellular, which is an expansile segmented lesion rather than collapsing. From its name, it looks like a cellular variant. You usually get some form of endocapillary hypercellularity. The main cell infiltrates are usually foamy histocytes. Some people debate that this variant even exists and that this is just an early stage before the sclerosis. This is one of our cases, and this is, as you can see, a highly cellular glomerulus with all of these vacuoles are foamy histiocytes. And this is a typical variant of FSGS. When we come to really apply this as clinical pathological correlation of the variants, as I mentioned, FSGS, NOS is the most common variant, and it's equally distributed among whether primary or secondary forms. Perihilar FSGS is more common to see in secondary forms of FSGS, but can also be seen in genetic forms. Ahmed is going to discuss the prognosis and the response to treatment. This is usually the one we call maladaptive. The TIP, cellular, and collapsing variants usually share the presenting features of that these patients have nephrotic syndrome, a heavy proteinuria, but some, as the cellular variant, can present with subnephrotic range proteinuria. The TIP variant is the usually presents with a full-blown nephrotic syndrome and with very high proteinuria. It has a strong predilection for whites, high remission rate, and the best prognosis, while collapsing FSGS also presents severe nephrotic syndrome, but also rapid progression to end-stage renal disease. These patients present with nephrotic syndrome and usually renal failure. And it has a very strong predilection in patients with African heritage and carries the worst prognosis. And hence, it's very important to recognize the collapsing variant as we are starting to consider it. We even have now a talk about that we are going to get it out of the FSGS spectrum because it really represents a specific disease entity on its own. As I mentioned, cellular FSGS has a very low incidence, is an extremely rare variant, and its prognosis is somewhere between TIP and the cellular variants. Ahmed, would you like to discuss the pathogenesis?
Excuse me, please, Professor Wesam, I want to stress on some point for myself. You said that the pathological lesion, you can find single pathological lesion with many one or two etiologies. It is not necessary for the one pathological lesion to fit into a single etiology. Is it right?
Yes.
Yes. Thank you.
The variants can help you to have some form of a differential diagnosis. Yes. Can guide you, but at the end of the day, they are not characteristic or pathognomonic of any special etiology.
Yes, okay, I want to stress this point. The variant, single variant in the biopsy does not mean a single etiology or a specific etiology.
No, it doesn't. No, it
Thank
doesn't.
you. You said that regarding a pathological lesion, when we faced with a tip lesion, it somewhat carries a good prognosis and a response to treatment. And if we faced with collapsing lesion, it carries a bad prognosis. I'm right?
Yes, as we are going to see.
Okay, thank you.
Okay, thank you.
My last question.
Wesam, there was a question from the
Yes.
audience. If you can find more than one type in the same biopsy?
You mean, well, for the specific types, no. If you can find a combination for TIP and NOS, yes, and then we are going to call it a TIP variant.
Yes.
But it's no, it's not common to find. You cannot find TIP and collapsing, for example. You have to make up your mind which one it is.
It is usually one. It is usually carries one variant in a single biopsy.
Exactly.
Okay. You said that it's essential, not essential to be sclerosis. It may be proliferative.
Yes, of course.
Okay.
Can it carry some difficulties in the differentiation of other?
Definitely. Definitely.
Can it carry some difficulties in differentiating with other proliferative lesions?
Yes, yes, yes. It's misdiagnosed sometimes as being focal proliferative, especially the cellular ones.
And can you explain to us how can we differentiate? How can we know from the biopsy if it creates with the proliferative lesion in a biopsy?
Well, you need to do further studies. You need to do immuno and you need to do EM. And then when you don't have any evidence of immune complexes and the patient serology is negative, then this is just simply an FSGS.
Here comes another message that we are to collect all the clinical picture and all other investigations in addition to the biopsy.
Exactly, as we're going to show you, hopefully by the end of this session, that this is a clinical pathological diagnosis. It's not a pathological diagnosis and it's not a clinical diagnosis. They have to be together, hand in hand.
Thank you. Professor Ahmed, go please.
Okay, so let's move on. For the epidemiology, actually, the incidence varies, as you know, between different populations. It might vary from 1.4 per million to 21 per million. And it's definitely higher in Black population, some type of genetic predisposition or predilection, like for the non-muscle myosine and the APOL1, which we might came to on the way. So, I mean, for instance, in our region, especially in the sub-Saharan FSGS, primarily in our population who presents with adulthood or adolescent nephrotic syndrome. When it comes to the pathogenesis, there is a very important point here. As Wesam mentioned, the podocyte almost in all her slides, and the podocytopathy, the podocyte hypertrophy, the podocyte deletion, and it is cytopathic, and can be or immunological or genetic insult. And a very important issue, FSGS, that with the lesion occurring in the podocytes, the glomerular basement membrane started to be denuded, started to be bare of the podocyte coverage, where it starts to come to interact with the parietal epithelial cells, hence forming the starting of a synecdoche, or if you would say, the sclerotic area with excess deposition of mesangial matrix and attachment to the parietal layer, and then you would start to have this part of the glomerulus, which, as Wesam shown us, at least 12% of the glomerular size is to be sclerosed. And this is the example for when you have the podocyte deficiency with the M that comes to interact with the parietal epithelial cells to start to form this part of sclerosed glomerulus. And this very nice pictograph of the electron microscopy showing at panel A the normal pattern of the podocyte that covers most of the glomerular basement membrane in this interdigitating way. Then you start to have retraction with the effacement of the podocyte, and you start to have some areas that is not totally covered, and then it goes further, like in panel C, when you have this yellow area that is totally avoided or divided from the podocytes, and this is the main pathogenesis again. So it's a podocytopathy, if you would like to say podocytopenia, and the trials for the width of the podocytes to cover the denuded area comes into hypertrophy of the remaining podocyte. As you know, podocytes are not cells; it cannot regenerate. It's not like the tubular cell. So they started to try to hypertrophy to cover the remaining defective area of the capillary surface, and this leads to compensatory intracapillary hypertension and endothelial cell injury. And as you've seen from Wesam slides, that the endothelial cells are affected and the endocapillary cells are affected, although it starts at podocytopathies, but you would have multiple cells in the glomerulus affected. The cell-to-cell propagation of the podocyte injury explain the characteristic segmental nature. It's not like it's like infecting the neighboring cell. It's not an infection, definitely, but it's like infecting the neighboring cell, cell by cell. So that's why it causes a segmental rather than widespread in the whole glomerulus. This is the key point for being segmental. Let's start with our first patient. We've just gave you an idea about what is FSGS as a pathological entity, not as a disease entity, and the common variants in the up till now pathological classification that might be or that's expected to be changed, and the pathophysiology and the epidemiology. So let's go to the clinical work. This is a 34 years old male patient presented with a full-blown nephrotic syndrome with a proteinuria of 14 gram, albumin of 2.4 gram in the serum with a normal renal function. His collagenous markers were negative and CC and C4 were normal, as well as the virology that was negative. And the biopsy done, and it showed FSGS not otherwise specified, with the EM showing more than 80% effacement of the food processes of the podocytes on electron microscopy. So this is a full-blown picture of nephrotic syndrome in a middle-aged man, and he had an FSGS NOS type with extensive effacement of the food processes. And this was his biopsy finding. As you can see, there was a 35 glomerulus, and 8 of the glomeruli, I think it's pretty good number, Sam. You cannot say 8 of them showed segmental tuft sclerosis with focal overlying epithelial cell hyperplasia. These are the key words for the proper diagnosis of the type of the lesion, and capsular adhesion located randomly within the tuft, and the rest within normal limits, which tubules were unremarkable, and interstitium within normal limits, and this is a gray kidney. That's why he had a normal kidney function, but this extensive proteinuria. We should go from here. What do you expect from this patient, and how can we go through? I'll stop sharing.
Dr. Ahmed, please, the proliferation here, the cellular proliferation here is epithelial cells, not inflammatory cells. Here?
Yes, definitely.
Yes, definitely.
No, it's not proliferation. It's hyperplasia. This is an important
hyperplasia, epithelial hyperplasia.
Yes. This is an important issue. Podocytes do not proliferate. Podocytes do not proliferate. Mesangial cell
Yes.
can proliferate. Definitely parietal epithelial cells can proliferate, but podocytes do not proliferate. They got hyperplastic,
That's why
they got foamy inclusion bodies, as Wesam showed us earlier. Wesam, would you go there?
Let me answer this. Yes, podocyte injury mainly could that you don't have any change in the podocyte number, and this is what we see in minimal change disease. This is why we consider minimal change disease and FSGS the spectrum of podocytopathy. So when you get a podocyte injury, if the injury is mild, you don't get any change in this podocyte number, and this is what we call minimal change disease. You can get podocyte detachment and death, as Ahmed just explained to you, and this is what we call FSGS. However, you can also get podocyte proliferation, as Ahmed was just mentioning, and this depends. If you have a low proliferation, we get the disease known as diffuse mesangial sclerosis, and this is only seen in children or in infants, or we get high, a lot of podocyte proliferation, and when it's significant, we get what we call a collapsing glomerulopathy. And hence, between the spectrum of FSGS and the collapsing glomerulopathy, you can always find some podocyte hyperplasia through the way. This is why we call it just a hyperplasia, and it's described as hyperplasia, not as actual proliferation.
This means that podocyte proliferation with collapsing variant, when we go with podocyte proliferation, it comes with bad prognosis, huh?
Yes, but it depends on the podocyte proliferation, on the epithelial cell hyperplasia.
Okay.
It depends. It's not any FSGS can have epithelial hyperplasia. Any type of FSGS can have associated epithelial cell hyperplasia. This does not denote anything. If the hyperplasia is a lot, and you have collapse of the glomerular tuft, then this is what we call a collapsing variant. So collapsing variant depends on the collapse of the glomerular tuft rather than the epithelial cell hyperplasia.
Okay.
Okay.
Are we clear about this? This is what we call an NOS variant, because simply it's not, you cannot determine where it is. It's located as mentioned in the description randomly. This is the arteriole, by the way. I know it might not be apparent for you. It's present in the center of the tuft. This is of course because of the plane of the suction. However, you can see this pink solid areas. This is what represents the segmental sclerosis, and it involves almost 50% of the tuft. So this is actually advanced FSGS, and this is what we call an NOS or a classic variant. This is another example. Now the hilum is clear on the right, on the right hand below, and you get these hyalonotic nodules. So if this is only what's in the glomerulus, then you would call this a perihilar variant. However, you can see that you also have this sclerotic lump at the tip, completely opposite to the hilum. And again, if it's alone, then we're going to call it the variant. When we have both of these morphologies together in a single glomerulus, then this is what we call NOS, or not otherwise specified. Exactly. Ahmed, shall we move on to case number 2?
Yes.
And I'll stop sharing.
So regarding this case, Dr. Ahmed, what is they suspect to be a primary FSGS?
That's an excellent question, Dr. Yassi. Yes, actually, this case actually based on the biopsy finding, and this is an important point that you would go through in both in the clinical and the biopsy, and we'll discuss this point, that you can have a strong suspicion from the clinical presentation as well as from the pathological finding of whether this is a prime, secondary, or genetic, or whatever, as we're going through. So the second case is a 55 years old male patient. He's diabetic and hypertensive for 5 years. And of course, we have to mention here that you should always have a good index of suspicion for biopsying diabetes or patient with diabetes if they have an abnormal presentation that does not fit with simple diabetic kidney disease. He presented with generalized severe volume overload, heavy proteinuria of 15 grams, severe hypoalbuminemia, and renal impairment with the creatinine of 4. This was a stormy presentation that occurs over maybe 2 to 3 months. The patient was put in Arabia, and he came back for this stormy presentation. He was admitted, he received IV albumin and diuretic to correct the general condition, and a biopsy was done. And the biopsy showed a tip variant FSGS. And here you can find at the biopsy report that the tip variant was with a 25% focal global glomerulosclerosis. And take care of the terminology. This is a focal global glomerulosclerosis, which Wesam will get or test that he had an acute tubular injury that was possibly toxic, and he had mild interstitial fibrosis and tubular atrophy with moderate arteriosclerosis and arteriohinosis that fits into the hypertension and diabetes. And the comment was that tip lesion usually behave as minimal change disease, so search for an underlying malignancy is recommended. You have another, as you know, that sometimes you should look for secondary etiologies in some patients. Okay, so this was the second case. Yes, Dr. Yasser.
I think this stormy presentation does not fit with the minimal change disease, and if you agree with me, it's not caused by FSGS. It's caused by
not minimal. No. Well, this is not a minimal change disease. It was just a comment that tip lesion in FSGS might behave like a minimal change, but we cannot say that this is a minimal change disease.
If I might comment.
Okay, please.
Yeah. Well, what's meant by the comment.
Put your yes, Wesam.
Okay. Now, this patient did not have only the tip lesion. He also had an acute tubular injury. Yes, this is why his creatinine was high, and probably this tubular injury was caused by the proteinuria he had. As you can see here, we have on the right side of this glomerulus a lesion. It's segmental, only involving less than 10% of the glomerulus. And this lesion is not sclerotic. This lesion has all of these vacuoles, which are simply foamy histiocytes, and you have an overlying podocyte hyperplasia. And in the glomerulus below, you have the same lesion again, and you have all of these foamy histiocytes. And it might not be apparent to show you on other glomeruli. Yeah, again, you have on the picture on the left this glomerulus with early sclerosis at the tip, and it's herniating into the tubular pole. And then you have on the right a glomerulus with this sclerosis. In the right picture, you have on the left this space, which is the hilum, and then you have on the right of the picture this pink area again, a solid area which represents the segmental sclerosis with also foamy histiocytes. So within the same biopsy, you can find the FSGS at several stages. Some of them were quite cellular, still very cellular lesions with foamy histiocytes, and you can find the other glomeruli already sclerotic or completely sclerotic or having an advanced sclerosis. So not all glomeruli go through the same progression within the same time frame. And this is why some of the lesions can be missed. And this is why you can only, sometimes you have a very advanced disease where you don't know where it is. Now this patient luckily had EM, and with EM, when you have more than 80% effacement of the porocytes, again, the large picture on the left shows a low power view of the EM. You should have told me that we're not in full screen. Okay. Now this is, you can see that they have diffuse podocyte effacement, and there is a higher power on the right with a glomerular loop. And you do not see these small spikes, which represents the food processes of the porocytes. You rather see a diffuse layer, and this is what we call diffuse effacement of the porocytes. And you see all of these villi or all of these particles which are present outside or close to the podocytes. This is what we call microvillus transformation of the podocytes, and it represents severe injury of the podocytes. This picture is a pathognomonic for a podocyte injury. And since the basal membrane is normal with normal thickness and normal structure, and we don't have any electron dense deposits, and the immuno of these patients were completely negative. So this is definitely what we would call, and the patients presented with full-blown nephrotic syndrome. So this is, with confidence, is a primary form of FSGS, the first patient and the second patient. Now let me explain the comment. Well, we know that when we get minimal change in adult minimal change disease, that we have a good percentage of these patients which could be secondary to malignancies. The fact remains that also FSGS is a podocytopathy like minimal change. So when you get an elderly patient, or not elderly, I withdraw it, any patient who is over 50 years old with a primary FSGS, that means with a podocytopathy, then you also have to screen for malignancies as you do for membranous and as you do for minimal change. This is what's meant by the diagnosis, that specifically TIP variants, who represents again a podocytopathy and a very close entity to minimal change, could also be secondary to malignancies as minimal change.
Thank you for this clear message, Professor Wesam. TIP variant does not only implies a good prognosis, but also we should screen when we found the TIP variant. We should deal as if it is secondary minimal change, searching for malignancy or other secondary causes, especially in old patients like this. And the acute lesion can be found due to the presence of other types of pathology other than the TIP lesion in the cases of FSGS. Thank you for these clear messages.
Okay.
Okay.
Okay, so from here we can go for the classification. And these are very important points, and we're going to overstress these many times throughout this night and this session. The type of damage, the rate of progression, severity of podocyte injury, they vary considerably between primary and secondary FSGS. This is an important issue. It's very important as it comes to go forward because it's important in the treatment. It is important in the prognosis. It is even important in the decision of transplantation to diagnose whether the patient is primary, secondary, genetic, or whatever. So in primary FSGS, there is rapid global damage of the podocyte. There is an abrupt clinical onset, and there is an extensive podocytopathy in more than 80%, as Wesam earlier said. Whereas in secondary FSGS, there is a slower, more sustained insult. Clinical evolution is progressive but slow. Podocyte effacement is relatively mild under electron microscopy, especially in the early phases before it become very extensive. And when it goes to pathogenesis of FSGS, it comes to the permeability factor that we've been looking for this permeability factor for years and years. And I assume for everyone who is at least 10 or 15 years in the field of nephrology should have heard about many suggested permeability factors, nephritic factors, and SUPAR and the anti-CD40 and many others. But it looks like it is a debate and still a vein. We were not sure. It's hypothesized to be a cytokine. It could be an isoform of the ApoA1. It could be the anti-CD40 or the serum urine type plasminogen activator. But the best evidence that it is there, that is the rapid recurrence of FSGS within hours to weeks after kidney transplantation. I mean, when you got the kidney from a normal person and you put it in a patient with a primary FSGS, and you have nephrotic syndrome few hours or few days or a couple of weeks transplantation, something serum of the patient that causes the disease in this normal kidney. And this is a very nice case scenario. It's a remarkable case, actually, that definitely show the hypothesis of the permeability factor that we still do not know exactly what it is. Simply, a patient was transplanted secondary to primary FSGS, and he had an early recurrence. They were brave enough to took the kidney. So the transplanted kidney was nephrectomized from that patient, because they know that if you leave the kidney with this very early recurrence, you would lose it very early. What they did is they took out the kidney, they put it in another patient who was a diabetic patient, end stage secondary to diabetic nephropathy. And the kidney worked well in the diabetic patient with no nephrotic syndrome, with no evidence of FSGS that was evident with the biopsy in the first. So it was the same kidney. It showed primary FSGS when it was transplanted. The primary FSGS patient, when it was taken out and it was put into the diabetic patient, the lesion was ameliorated. So I think it's very convincing that you have a serum factor, which is still we don't know, but we call it a permeability factor.
Yes.
To another patient.
Excuse me, Professor Ahmed.
Okay.
Can I stress?
Yes.
Can I stress on your message that podocytopathy is important regarding renal biopsy and electron microscopy and differentiating primary and secondary forms of FSGS, which is essentially and very important in preparing for transplantation. Okay, is this your message? Clear?
Yes. Yes. Exactly.
Yes.
Along with the long scenario that nephrotic syndrome to more or less in the course, in the appearance, I mean.
So
okay,
EM is very important in FSGS, not simply light microscopy. Okay.
This is a very important message. Yes, EM is very important.
Thank you.
Okay, the third case, she's a 32 years old female patient. She presented with proteinuria. Now the proteinuria was less than nephrotic range. And I would, although it's out of our scope tonight, but I would like to point out that doing proteinuria and albuminuria all together is a good thing to be done, especially those days with the upsurge that we are facing in the paraproteinemias with the different types. So it's a good thing to do albumin creatinine ratio and protein creatinine ratio all together, like when you do total albumin and serum protein. And if you find the big discrepancy between the proteinuria and the albuminuria, or between the serum albumin and the total protein, you would always think about some sort of paraproteinemia or abnormal protein in the serum and hence in the urine. But this patient had a concordant ACR and PCR. She had an AKI with a serum creatinine of 2.8. Her profile for the immune battery were all negative. C3 and C4 were normal. And the feature segmental glomerulosclerosis, again glomerulosclerosis. This was associated with moderate interstitial fibrosis and tubular atrophy and moderate arteriosclerosis. And again, the comment was that focal segmental glomerulosclerosis noted could present a post-scarring process. This is a very, very important comment, actually. And you would respect comments when it's the clinical scenario. I mean, this is not a patient with a full-blown nephrotic syndrome. She had already some sort of renal impairment with the subnephrotic range of proteinuria, and the comment was speculating a post-scarring process due to necrotizing GN, especially within the context of the tubular-interstitial reaction and the red blood cell casts that was present in the glomeruli, in the tubules in the biopsy. And thorough investigation for small vessel vasculitis profile, including lupus, is recommended. She was lupus negative, by the way. So this was the third case. And I'll mention the fourth case and leave Wesam to comment on both cases together. This was the biopsy, and this was the comment which Wesam will show us, that there were 12 of the patent glomeruli showing segmental tuft sclerosis with focal oval and affection. Again, another case, a 55-year-old female with nephrotic syndrome with and this time the nephrotic syndrome was brachynephrotic. Her albuminuria was around 7 grams. Creatinine was 1.5. Her serum antiplur was positive, was highly positive actually. And the biopsy was done, and the biopsy showed membranous nephropathy with a secondary FSGS, a feature that is often overlooked, maybe in reporting in a lot of labs and in clinical consideration in a lot of clinical scenarios. Renal biopsy showed that the membranous nephropathy and it was suggested to have serum FSGS and mild tubule. And the immuno of this patient at that time, the antiplur was not available, but the IgG was positive and T3 was positive along the glomerular basement membrane. Wesam, I would leave you now to comment on both cases.
Till we shift the screen if you have a question from the floor? They were asking about the case
okay,
you
I've
mentioned.
already
Asking about the case you mentioned in second case. Did they take a biopsy? The FSGS that was transplanted in a diabetic patient. Did they take a biopsy from the transplanted kidney before nephrectomy?
Yes. The kidney. In this particular case report, they biopsied the kidney when the patient got nephrotic syndrome after transplantation, and then when it was proven that it is FSGS, they took out the kidney and they put it into the diabetic patient, and then they waited, and then they re-biopsied the patient, and there was amelioration of the FSGS.
Another question, pure pathology, could FSGS, none otherwise specified, be an advanced form of other variants or can be a separate entity? Professor Wesam, can you hear me?
Yes, I can hear you. Can you repeat the question, please?
Could FSGS, none otherwise specified, represent an advanced form of other variants simply, or be a separate entity?
No,
can be a separate entity.
It represents an advanced form of other variants. This is very true.
Advanced form, cannot be separate entity. Yes.
No, but it also represents advanced forms of secondary FSGS, as I'm going to discuss now. You have other questions?
No. Okay. I see that the audience got started to get all messages. Thank you for your clear message.
Thank you. So now this is the biopsy of case number 3 of the female patient where we added the comment, which she had an FSGS, where we added the comment that it could be a post-necrotizing lesion. That means simply that this is not FSGS, the disease we know. This is just what we call non-specific scarring of the kidney. Why did we suspect it? Because, as was mentioned in the biopsy, she had a lot of tubulointerstitial fibrosis in relation to the time of her disease. She had also again a non-OS pattern, but more towards a perihilar variant. She had a significant vascular disease together with it. Look at her glomeruli. They were mainly ischemic with a lot of periglomerular fibrosis. And this is a trichrome stain. And you can see significantly the sclerosis, again, an NOS variant. So sometimes the biopsy, these highly scarred biopsies with the FSGS present in these ischemic glomeruli can give you a clue that it looks like a secondary process. It doesn't look like the FSGS disease at all. It doesn't look like a maladaptive form. It doesn't look like that this could be within the focal segmental glomerulosclerosis disease. It just looks to be a non-specific pattern, or what we call non-specific scarring. Again, and we also had EM for this patient, and as you can see, which is typical in secondary forms, you get a segmental photocyte effacement. I'm sorry, I know you cannot see the cursor, but here you have.
It's clear. It's clear.
It's clear, great. So you can
Yes.
see you have here these are intact podocytes, while here you have what we call segmental podocyte effacement. So definitely the podocyte effacement in these biopsy was minimal. Again, here this is a segmental podocyte effacement in the picture on the right, and you have here intact podocytes, and this is what we call segmental effacement. So as we're going to discuss later, I just don't want to confuse you. When you get this segmental podocyte effacement, you're out of the category of a primary FSGS, but you can still fall within the differential diagnosis of what we call a genetic FSGS or a secondary FSGS. So secondary FSGS, whether to maladaptive forms or to hypertension or systemic diseases, blah, 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 is something different than what we consider non-specific scarring of the glomeruli secondary to a primary glomerular disease, like what we're discussing here. And true to the point, as Professor Ahmed said, the patient turned to be lupus, which was not recognized. As for case number 4, she was a straightforward membranous, again with significant secondary segmental sclerosis. Now, why is it important, since we already have an identified glomerulonephritis and a clear cause of the patient's nephrotic syndrome? It's important because this is one of the main histological prognostic factors in membranous nephropathy. So actually, when you have a membranous patient, you have to look at these prognostic factors, as we're going to discuss in membranous. However, one of them is the presence of what we call secondary FSGS. And as Ahmed mentioned, this patient's immuno was all positive and very clear, straightforward for membranous, but we also had EM for this patient. And as you can see, you have this nice subepithelial electron dense deposit, all of these lumps. Here again, here subepithelial, this is the podocyte, this is the endothelium fenestrated, and a very clear endothelium, nothing wrong with the endothelium. And you can see the electron dense deposits here, just below the podocyte. But what I want to show you is not the membranous. I want to show you that here, you also have a diffuse podocyte effacement. So the diffuse podocyte effacement is only significant when we know what disease we are considering. So this is why we say you cannot diagnose only from a single modality. You need to put all of them together. So you can have a diffuse podocyte effacement in all types of glomerulonephritis. Once you have immune complexes within the glomerular basement membrane, the podocytes are also going to be affected. But note here, you don't get the microvillus transformation and the significant swelling and enlargement of the podocytes, which we see in primary FSGS or in minimal change in a primary podocytopathy. So can we diagnose FSGS by immunohistochemistry? Can I know whether the patient has FSGS or whether this is primary or secondary? Unfortunately, no. Immunohistochemistry or immunofluorescence has no diagnostic role in diagnosing FSGS. Let me be clear. I cannot use immuno for diagnosis. Immuno is not going to tell me whether I have a segmental sclerosis lesion or not. Bear in mind, neither EM. Segmental sclerosis is a lesion which we see on light microscopy. If I can detect it on light microscopy, fair enough. So this is FSGS. If it's not represented in the biopsy, then I cannot call this patient FSGS, even with immuno, because I know that it's written in a lot of the textbooks, the medical ones, and also in some old references for renal pathology. FSGS will show IgM and C3. This is not true. This is not true. This is not an immune complex mediated disease. So you should actually question the sentence. This is mainly a porocytopathic disease. And if we have deposits, then you should consider in the glomerular tuft, then you might consider that you do have an immune complex mediated GM. However, within the sclerotic areas, you can have non-specific deposits of IgM and C3, or might not be very non-specific. So to diagnose FSGS, I have to see the segmental sclerotic lesion on light microscopy. But do we have to do immuno? Yes, we have to do immuno. Why? Because without immuno, we cannot diagnose an underlying membranous like in the previous case. Because sometimes, as you see in this picture, the FSGS is very advanced and you cannot really see clearly the basement membrane. So without immuno, I wouldn't know that this patient is a membranous GN with secondary FSGS. Without immuno, I wouldn't know that this FSGS represents an IgA nephropathy. Without immuno, I wouldn't know that this patient could have a lupus GN and so on. So immuno is very important within these cases of FSGS to diagnose that it's only an FSGS and that we don't have any other GN, not to diagnose FSGS. Recently, a couple of years ago, there was this paper which was published upon the clinical significance of IgM and C3 glomerular deposition in primary focal segmental glomerulosclerosis. And the authors have looked at 106 patients with primary FSGS, and they have noticed that these patients with primary FSGS, and I'm very specific, with primary FSGS, if they have IgM and C3 deposition, they seem to have an unfavorable therapeutic response and worse renal outcomes. However, this was only a single paper, was not followed by any other validation studies or any other large cohort study, something which you could consider or might not. So,
thank you for you.
Yeah, what's important in this point, again, to sum up, that it's very important to differentiate what we call focal segmental glomerulosclerosis from non-specific focal global glomerulosclerosis, what we call FSGS, which is seen in any ischemic glomerulus on its way to obsolescence, or global glomerulosclerosis, as we've seen in the lupus patient, or that we have focal segmental scarring, post-inflammatory or necrotizing, which is associated with an immune-mediated glomerulonephritis like membranous, like IgA, like ANCA, and like in lupus nephritis. So the last two cases presents non-specific focal scarring of the glomerulus and does not represent FSGS. So the term FSGS, which was in the diagnosis, this is what it represents, this focal scarring. And because the nephrologist was keen and he understood the language of the report, he went further, investigated the patients, and the patients turned to have completely different diseases than the histological pattern which was present in the biopsy. So you can see here on the left, this is what we call a focal necrotizing lesion. And when this focal necrotizing lesion is going to heal, this is what's going to give you on the right, a segmental sclerotic lesion, an FSGS. But you cannot call it any other thing. And this is what we call FSGS, or focal global glomerulosclerosis. This is what we call a global glomerulosclerotic glomerulus, or an obsolescent glomerulus. If these globally sclerosed glomeruli are present in less than 50% in the biopsy, then this is what we're going to call focal global glomerulosclerosis. And it indicates that if there is a glomerulus with FSGS, this glomerulus is probably also on its way for global sclerosis. If you look carefully at this one, then you will see that you do actually have segmental sclerosis here. It's not fully globally sclerosed yet. So it is the job of the pathologist to be able to determine as much as they can whether what they see on the biopsy is non-specific scarring or really represents the primary disease, as in FSGS, whatever the type of FSGS, whether it's primary, secondary, or genetic. This is different than the fact that you can have non-specific scarring secondary to any other GN or any other disease, as much as they can. and not just to call it all, not fall all under the pool of a focal segmental glomerulosclerosis.
Excuse me, Wesam, and to stress for myself, and I know you will tolerate me because if you are my friend. When we find the words focal glomerulosclerosis, we should differentiate. Is it segmental glomerulosclerosis or global glomerulosclerosis? Global glomerulosclerosis is
you
a
have
process.
To read what you have to read
Yes.
the word behind the focal.
Behind, in between the two words, focal and glomerulosclerosis.
Please do, yes, please do.
Is it global glomerulosclerosis
or is it segmental?
If it's segmental, we should not take it as a benign lesion. We should search about it. If it's global, it can be the usual process or the usual story of the glomerulonephritis and passing into end stage or as a chronic kidney disease. Definitely. I'm clear? I'm right?
Yes.
Thank you.
Definitely.
Thank you for this clear message. It's very clear message, and very important message. How to interpret? It is not take the word focal glomerulosclerosis as a simple lesion. Please stress the word in between. Is it global or is it segmental glomerulosclerosis? Okay. Thank you. Ahmed?
Okay. I will add to very, very nice briefing of the terminologies that, again, this is different from focal proliferative. So you can have focal global, you can have focal segmental, you can have focal proliferative, which is another issue. So don't for our junior colleagues, don't just treat focal and go for FSGS. Focal
I'm speaking about. I'm speaking when you find glomerulosclerosis and focal. First, glomerulosclerosis and focal. You should search: is it global sclerosis or segmental sclerosis? I think proliferation is another issue that we should not be mistaken for this. Cellular and inflammatory cell infiltrates and so on.
But when it comes, again, it comes to the focal word. Usually things are perplexing. This is of FSGS. What is result match between the load and the glomerular capacity? You know the usual term that we used to say a long time ago, maybe a couple of decades, the single nephron hyperfiltration. It is an excess load per nephron that carries these specific glomerulus to start to sclerose. And this can occur with a low nephronal endowment at birth. That's why you can find this in people with low birth weight, with premature labor, are more subjected to these types of lesions. Renal anomalies such as reflux nephropathy with a scarred kidney, hypoplastic kidney, or overweight, obesity, high protein like in gym nephropathies and excessive androgen abuse. And even with AKI, as you know now, the recent literature is showing that AKI is not simply an insult that goes, it leaves a scar in the kidney, and people who suffer from an AKI are more to suffer from CKD in the lifespan. And FSGS is one of the mechanisms of having these patients like this. And any chronic glomerular tubular disease that may reduce the total nephron function, and this was very good example in the last two cases. They were both non-FSGS diseases that culminated in some focal segmental scarring and focal segmental sclerosis in the kidney as a maladaptive response. And of course, for FSGS,
Okay. All right. Well, we are sorry for this technical defect. So following up on what Ahmed was saying, that that within FSGS, we have to, apart from the morphological variant, we have subclasses of FSGS. And these clinical pathological entities of FSGS, these subclasses would include the primary form, as we've shown you in the first two cases, the genetic form, which we're going to show you, and the secondary forms, which we already again demonstrated within the third and the fourth case. And as we've shown within the case, that their differentiation, and in order to differentiate between what we consider primary, genetic, and secondary, requires a very good clinical pathological approach. So the clinical data is very important, and a full pathological study is very important. Within the light microscopy features of primary versus maladaptive, yes, it's easy to diagnose, or easy to be sure that this is a primary FSGS when it's in its early stage, because usually you don't have any associated interstitial fibrosis and no vascular changes, and there are no chronicity in the kidney, and you just have this FSGS. And it usually presents with what we call an abrupt onset of nephrotic syndrome, or what you can call acute nephrotic syndrome. And kidney biopsy, which is done early in the course, and generally shows a relatively, as I mentioned, well-preserved parenchyma with only few glomeruli featuring the characteristic FSGS lesion, as we've shown you within the first two cases. So you can see here, this is a very nice kidney with a nice tubular interstitium and two glomeruli having the FSGS lesions. And this would be classified as tip variant. You can see here we have the hilum, is the tip, we have sclerosis at the tip. This is what we call the tubular pole. And again, another glomerulus with this large sclerotic nodule. It's not very apparent within this plane of suction whether this is the tip as well. But again, this is what you can easily diagnose as primary FSGS. In contrast, maladaptive FSGS often presents with progressive proteinuria. These patients do not have this abrupt onset of nephrotic syndrome. They have this slowly progressive proteinuria, and kidney biopsy is done usually later in the course, because the patients usually present with subnephrotic range. There's most of the time they're hypertensive. You guys do not biopsy them, so they are biopsied a bit late. And you get varying degrees of parenchymal scarring, which are often associated with what we call maladaptive FSGS. So look at the other side of the story. Again, you have this glomerulus with segmentosclerosis, which can mimic a tip lesion as well, which tells you that morphological variants are not really pathognomonic. They are just a guidance to a prognosis, but you can see that this kidney is already a bad kidney with a poor prognosis. They have a lot of interstitial fibrosis and interstitial infiltrate, have a globally sclerosed glomerulus, and you also have another glomerulus with segmental sclerosis. So in advanced lesions, as I've shown you in the case, this comes again from the case we've shown, advanced primary FSGS and maladaptive FSGS are indistinguishable on light microscopy. So if the patient is advanced, and we have a lot of FSGS, and we have a lot of interstitial fibrosis and scarring, we cannot tell whether this is primary or secondary. Electron microscopy could help. It would be very nice if we still have a patent glomerulus or a partially patent glomerulus, and we have this nice diffuse podocyte effacement or extensive podocyte effacement more than 80%, versus that you could have a podocyte effacement. However, if you want to identify a genetic form, EM is not going to be helpful, because unfortunately, genetic forms can present with both segmental or diffuse podocyte effacement. So EM is important because it can give you an idea whether you're primary versus genetic, or whether you're secondary versus genetic, and then you need the rest of the clinical pattern to build up your diagnosis. So kidney biopsy features that would support the diagnosis of maladaptive FSGS would include that you have a glomerulomegaly, large glomeruli, you have a preponderance of perihilar scars among sclerotic glomeruli, so you get a lot of periglomerular fibrosis, as you can see here. You have ischemic glomeruli, you have focal global glomerulosclerosis, you have globally sclerosed glomeruli, and you have partial or segmental food process effacement on EM, and a lot of interstitial scarring. So when we get to see this in advanced cases, yes, sometimes we can say that this is maladaptive, but really when the FSGS starts to be really advanced, it's really difficult to differentiate. As I've mentioned, in genetic FSGS, you can find both patterns, diffuse podocyte effacement or segmental podocyte effacement. As this very nice published case that this is EM findings in two siblings. Both of them had genetic FSGS. Both had they were heterozygotes for NPHS2 mutation, and so they were diagnosed as genetic FSGS. The brother had a serum creat of 1.1, a full-blown nephrotic syndrome, proteinuria 6.6 grams, though with a good serum albumin, heavy proteinuria, nephrotic range proteinuria, serum albumin 3.4, and his EM showed diffuse food process effacement, as you see on the pictures above. Diffuse podocyte effacement, while his 47-year-old sister had a serum creat 0.9, only subnephrotic proteinuria 2.5 grams, a serum albumin of 4 grams, and her EM showed segmental food process effacement, as you can see here. Look here, you have these nice podocytes, and then again this effaced podocytes. So it's really sometimes very difficult to know whether to call this primary versus genetic and whether to call this secondary versus genetic, but it can definitely tell you whether you're dealing with a primary or a secondary form.
Okay,
so
I'm back with if you.
You're back? Okay, this is
yeah,
my
I'm
last
back.
slide. Great,
Yeah.
great. Yeah, you're back in time for case number 5. So this is differential diagnostic characteristics of what we call primary FSGS, genetic, maladaptive, or focal global glomerulosclerosis. To sum up what we've been discussing, and we are going to repeat this again, as Ahmed mentioned, there are very important messages we want to highlight and repeat. So استحملونا and bear with us because we think this is very important. So again, primary FSGS will present with a full-blown nephrotic syndrome, usually with an abrupt onset. In light microscopy, you're going to get focal segmented global sclerosis. You're not supposed to have a lot of globally sclerosed glomeruli and no other damage within the glomerular duct, except if this is late in the disease, except if you're advanced. And it's uncommon to have glomerulomegaly, and in EM, you get a diffuse food process effacement. So this is a nice straightforward diagnosis. Then we have the genetic FSGS, which falls between both variants of primary and maladaptive FSGS, or types or subclasses, whatever you want to call it. And this is a bit problematic because these patients could have, as I mentioned, a full-blown nephrotic syndrome. It's less common in adults to have a full-blown nephrotic syndrome. Genetic variants, usually they have some nephrotic proteinuria, but they can also present with a nephrotic range proteinuria in adults, but not the full nephrotic syndrome. And this is a very important distinction because you sometimes, the juniors overlap it. I see nephrotic syndrome in the request, and then yes, it's a nephrotic range proteinuria, but it's a non-serum albumin. So be careful. There is a difference between both, and it helps within our diagnosis and with differential diagnosis, which we are considering. In these cases, you can get both patterns. You can get focal segmented global sclerosis, and you can also get a focal global sclerosis. And again, this is common in adults versus the juvenile forms. And as I just mentioned, in EM, it gets to be very variable. You can have diffuse or segmental food process effacement. And these cases really needs genetic studies. And as Ahmed, I'm sure, going to mention, genetic FSGS does not have to be familial. It can present as sporadic cases. Maladaptive focal global FSGS. Now, this again can have nephrotic or subnephrotic range proteinuria. But the most important point is that it's without a nephrotic syndrome. So you don't have the full-blown nephrotic syndrome. And in these forms, this is usually the perihilar form. You have other signs of scarring. You have focal global glomerulosclerosis. You have usually interstitial fibrosis. It's common to have glomerulomegaly. And by EM, you get segmented food process effacement. While what we call FSGS, or focal global glomerulosclerosis, is mainly a global glomerulosclerosis, but involves less than 50% of the glomeruli. Now, these patients can present with anything because this is not a very specific entity at all. This is usually variable proteinuria, usually subnephrotic, you get focal global glomerulosclerosis. You don't get a frank FSGS in the biopsy, no glomerulomegaly. These patients have ischemic glomeruli, and this is associated always with tuberointerstitial fibrosis and arteriosclerosis. And you get minimal or intact food processes in unaffected glomeruli. So again, this is an important point, because if I have a focal global glomerulosclerosis and I have this ischemic glomerulus I've shown you with this non-specific segmental scarring, and then this is the glomerulus we quote on EM, I'm going to have segmental effacement, because again, it's a non-specific finding. So in these cases, you need to examine unaffected glomeruli, highlighting the importance of early biopsies as much as you can, because as you see, features are much more clear depending on the timing of the biopsy. Okay, Ahmed.
Okay.
Welcome back.
So
Okay.
welcome back. So again,
Okay.
you discussed the clinic FSGS variants are mainly clinical variants, and the histological variant can fit in any one of the clinical variant with some limitations.
With some limitations,
Yes,
yes,
but
with what's common. It's just what's more common.
Yes. And the diffuse in electron microscopy, diffuse affection comes usually with the primary FSGS, while the segmental affection is not primary FSGS in 80% of cases. Okay.
The sting and the scarring and the glomerulomegaly are more like with secondary.
Secondary and
The primary, usually the kidney is fresh. Yes. Yes. Okay. So back to our patient. I don't know exactly where I was lost.
Let me start with this case.
Did you have first part of the patient scenario? The case again. Okay. So she was 19 years old female. She had severe hypertension, anemia, and heavy proteinuria, and rapid progression of renal function. And she started already hemodialysis and received pulse steroid with no value. She had a biopsy that was inadequate, and the pathologist suggested, because of some eosinophilic deposits in the glomerular capillary tuft, so it was suggested to have some sort of HUS vertebrae globs, and for the started on plasmapheresis. Again, she had no response. The patient presented to us at this point with urea 140 and creatinine of 15, almost with anemia and heavy proteinuria, some RBCs in the urine, and her all negative, thought that another biopsy is a must. And we did another biopsy. And the biopsy, as you can see, showed that 8 of the 32 glomeruli, which is 25%, is globally sclerosed, and 2 of the patent glomeruli showed segmental tuft proliferation with histiocytosis and early sclerosis, and other glomeruli showed ischemic changes with early periglomerular fibrosis, and the rest of the was within normal limits. And the immune profile were negative for all of these, but the moderate doses showed moderate doses, and it was only 19 years old. 19 years, yes. She was just a young female. And this was compatible with the focal segmental glomerulosclerosis collapsing variant with a 45% global sclerosis, and that needs some confirmation by electron microscopy, as would have been shown later, with moderate interstitial fibrosis and tubular atrophy. Now we came to a collapsing variant of FSGS that was shocking, and the history, the relatively rapid progression of the kidney disease and the poor response, and the amount of scarring and glomerulosclerosis and interstitial fibrosis in a 19-year-old female was shocking to us. So, Wesam,
would
you go for these biopsy pictographs?
Yes. Yes, please.
I stop sharing. Yes, here.
Okay. Okay, now, well, maybe the description, the microscopic description, the report was not very specific for collapsing, but this is what you get. You can see this glomerulus, and it looks very strange. I can understand, and all what we see within this tuft here is actually the epithelial cells. So all of these are the epithelial cells. All of what you can really see is the epithelial cells. So where is the tuft itself? It's only these red lines. So this is classically what we call collapsing glomerulopathy, because the tuft is collapsed. It's not sclerosed. You can see that still here they have lumen, they have extensive epithelial cell hyperplasia. Let me show you another example. You see, this is the remnant of the tuft. This is a collapsed sclerosed tuft. So here you can see the sclerosing, but also a collapsed tuft. It does not look like your regular global sclerosis. And you have all of these. What's left is the epithelial cells, which are present here within the moment's capsule. This was her parenchyma. She had a lot of global glomerulosclerosis. She had a tubular injury with a lot of pigment costs and this microcystic dilatation of the tubules, which is a frequent finding with collapsing variants of FSGS. When we get a biopsy with these tubular findings, we usually start looking for a collapsing form because they are usually associated with these forms. Upon silver stain, and silver show you the podocyte proliferation very nicely, or hyperplasia, and you can see here that you get a lot of epithelial cell hyperplasia significant. All of this pale cells are the epithelial cells, and here you have the collapsed, again, the collapsed tuft. And again, a very nice picture with a lot of reabsorption droplets. All of this pink bodies are reabsorption droplets. If I want to go back, now, why is this not a crescent? And actually, it's a very difficult question to answer. This is why we call it a pseudo-crescent, because also crescents are extracapillary epithelial cell proliferation or extracapillary epithelial cell hyperplasia. But usually crescents are associated with some form of inflammatory cells. We do see caryophysis. You get some spindle cells representing the fibroblasts, but this pure epithelial cells or pure podocytes are usually epithelial cell hyperplasia. Also, an important point is that podocytes in collapsing FSGS or in significant epithelial cell hyperplasia, they start to change. They tend to be large. They have they change their morphology because of the extensive podocyte injury they are in. So they get to be a bit bizarre than the regular podocytes. You see, the absorption droplets are a nice finding which helps to tell you that all what you're seeing here are only podocytes. If you look carefully, they are all the same cell. They are all the same nuclei. There are no inflammatory and nothing else within this moment's capsule, and a lot of reabsorption droplets. You do not get to see reabsorption droplets in cellular crescents. However, this is a very important overlap diagnosis, and it's sometimes with non-experienced renal pathologists or with general pathologists. Usually these pseudocrescents are interpreted as full-blown crescents, as I think this was the case here, because this was a second biopsy or a consultation a biopsy for us, and she was diagnosed initially as having a crescentic disease. Her immunohistochemistry panel was all negative, and as you can see, her EM actually showed only diffuse podocyte effacement, and there was nothing else. With extensive podocyte injury, no electron dense deposits within the glomeruli. So this confirmed her initial diagnosis, which was that this is a collapsing FSGS with 45% global glomerulosclerosis, almost advanced, and she had a moderate interstitial fibrosis and tubular atrophy as well of 40%.
Of course, it can be misleading, especially with the acute picture and increased serum creatinine can be. We can
exactly
the crescents can be logic diagnosis at this time. And
yes, it's a misleading diagnosis, and you need to. I mean, it can easily be misled into a crescentic disease when the problem is mainly. But the important point is the nephrotic syndrome.
the nephrotic syndrome.
It's the very heavy proteinuria. Yes, which don't forget this. Don't forget this.
We usually don't make this with absolute crescent disease, with to have just heavy proteinuria.
Just go back for this patient. Actually, we were in a puzzle. Why collapsing FSGS in that young female? She had definitely no heroin, no HIV infection. She did not suffer from a recent COVID disease. So it was perplexing, no evidence of any viral infection as well. So with the hypertension and the rapid progression and being already dialysis and having this collapsing FSGS, we started to look backward. By the way, she was more like, I wouldn't say Caucasian, but pretty white. But we started to go further, and we asked her father about the pedigree of the family or the ancestors of the family, and he then admitted that her grandmother was an African person. So this was, the clue for the patient that this could have been an APOL1 nephropathy, which presents by FSGS in adolescence or early adulthood with severe hypertension, and usually it is a collapsing type of FSGS.
So presence
and this goes to the
genetic.
Yes.
Yes,
the
finding of
one is a specific
finding of the collapsing variant can push us to the test for genetic abnormalities. Am I
right? Or think about genetic abnormality is a very tedious process that is not taken. Yes, but think about genetic FSGS. There are more than 50 genes that have been described. Some of them are like Wesam showed earlier in the NFS2 and 1 and the nephrin and the cytoskeleton, and these causes even the finished type NPHS1 and 2 causes the finished type of nephrotic syndrome in childhood. All these are types of genetic aberrations or abnormalities that can cause nephrotic syndrome in different ranges, from the congenital finished type up to a nephrotic syndrome that looks like secondary, slowly progressive with subnephrotic range proteinuria, like what happens with the collagen type 4 deficiency, and these are that deficiency protein, the affected protein, its relevance to the structure determine the severity of the damage, whether it would be like diffuse food process effacement with severe congenital nephrotic, or just a cytoskeletal disorganization with a type that is more like secondary FSGS. And this table is a very nice table that differentiates the primary FSGS from the genetic, from the APOL1 FSGS, from the maladaptive FSGS, from the infection associated and the drug associated FSGS. And Wesam had shown some of these tables earlier, including the history and the clinical presentation and the biopsy finding. And we would come later to the treatment and the prognosis and the recurrence after transplantation. But there is an integral point at this point that we should mention, at why we exhausted ourselves 1.5 hours now, exhausting ourselves trying to differentiate primary from secondary, from genetic or other types of FSGS, because the treatment relies on diagnosing what possible FSGS. Do we have not only the treatment by immunosuppression and or
Ahmed, we lost the voice again.
You lost the voice again. We have a remaining فاضل لنا كيس واحدة.
فاضل لنا كيس واحدة بس يعني we can skip it وننقل على treatment على طول.
Can you hear me?
Yes, of course.
Yes, we can hear you now. Yes.
Okay. So
you're not sharing the screen.
For the prognosis, the screen is now shared?
Yes, your screen is shared.
Can you see the screen, Wesam?
Yes,
we can see. شايفينها يا دكتور؟
FSGS prognosis. Yes. سامعينك دلوقتي. ما كناش سامعينك قبل كده.
ايوه سامعينك دلوقتي.
On biopsy. Biopsy and whether the patient's black or not. So during the disease course, whether he achieved partial or complete remission, and whether he have uncontrolled hypertension or not, and the histopathological features, whether the patient had variant, tubulointerstitial fibrosis, and mesangial and IgM or C3 deposits. Okay?
Okay.
I'm sure what's happening. Oh. Okay. And focus factor for progression toward end-stage renal.
Dr. Ahmed, if you have a problem, we can make a specific session for the treatment. If you can hear me.
I can hear you, yes. Can you hear me?
Yes, but with difficulty.
Hello?
Great difficulty. We can make a specific session later on for the treatment.
Okay. So there's a problem with the. Okay. What we have left, I will only wrap up. What we have left is the prognosis and the risk factor for progression, the treatment, and the recurrence after transplantation. This is what we have left in the session. I know it's a bit of a long or lengthy session, but this
deserves.
is FSGS.
It deserves and carries a lot of messages.
Yes.
How to differentiate pathologically, how to interpret the renal pathology in a clinical form, differentiating, trying to catch the diagnosis, trying to catch the etiology. Is it primary? Is it secondary? Is it drug-induced or maladaptive? And going into the prognosis and treatment later on. We get a very important message later on, depending about the electron microscopy, differentiating primary from other causes. And the prognosis depending upon the histological lesions. If it's step lesion, carries a good prognosis. And collapsing lesion, which carries a bad prognosis. Usually also the difference between the word glomerulosclerosis, is it segmental sclerosis or global sclerosis? Which is very important differentiation and in interpreting the biopsy and going on later the clinical. If you find a problem of segmental sclerosis, you are to search and go, don't stand here and search behind this word. Also, if FSGS can be present behind another diagnosis, such as the case of membranous, can be present in addition the acute presentation, but the presence of nephrotic range proteinuria raises the differentiation between real crescent and pseudo crescent. Is this crescent is real crescent or pseudo crescent? And don't rush to the diagnosis of the crescentic GN if you have such a nephrotic range proteinuria. This what I have learned from your presented cases really, and was a clear message and repetitive messages from your cases. Do you have another message or additional message that I lost in this resume?
I think Ahmed, you can just jump to the final slides for the treatment and the responsive therapy for the different patients we have presented.
Okay, if time would allow,
yes.
we can
the last few slides. Yes, skip. We can skip.
Okay,
all what's left.
Just this case. Okay. This case, just because of the prognosis, he was a male that presented with plant 6. He had the disease after 3 years, and he was retransplanted in 2010 and maintained on classical triple immunosuppressive therapy, cyclosporin based. 1 year later, he started to develop proteinuria, and the graft biopsy was done at that time. And to cut a long story short, the biopsy initially showed some manifestation that was not conclusive, but the patient, the biopsy showed initial FSGS, although the patient has a subnephrotic range proteinuria at the time, but later on, within a year of time, the patient actually developed full-blown nephrotic range proteinuria, and he started to have a full recurrence of FSGS with, again, a failure of the second graft. And this comes to the FSGS in kidney transplant, whether it is recurrent or de novo, there is an inferior 5 years graft survival, and the difference is more pronounced in pediatric population. So if you have a child who had an end-stage disease secondary to primary FSGS, the recurrence rate would be much higher, and the survival of the graft would be much lower. Are you following, Dr. Yasser? Hello. سامعيني؟
سامعينك يا أحمد، سامعينك.
Okay. So the recurrence after FSGS again can be sudden, can be very early, first days or even hours, and in the first 2 years post-transplant is the most common, and it's strong predictor of graft outcome, and it leads to graft loss in almost 50% of patients within 50 years. Okay, this is an important point because there was a question about this point. Did plasmapheresis help? Actually, it does not help in reduction of the recurrence as a prophylaxis, but it might help as a treatment when the patient had a. So there's no role for prophylactic plasmapheresis, but it might have a role as a treatment along with other immunosuppression, and these are the risk factors for recurrence: childhood, rapid progression, initial steroid sensitivity, white race, loss of previous allografts due to recurrent FSGS, and the patient receiving live donor grafts are more likely to have recurrence with severe hypoalbuminemia and absent family history.
how Ahmed, we lost you again.
I can hear you, Sam. Can you hear me?
Yeah, I
Yes.
can hear you now. Yes.
But the voice is on and off.
Should we stop here for the treatment, Dr. Yasser, or should we continue? What do you think?
I
think we should stop and leave it for a single session to illustrate it properly.
Okay.
Single
Okay.
specific session. Okay. Thank you for this, Professor Ahmed and Professor Wesam, for this session.
Thank you very much, Yasser, for the invitation.
Thank you for this your illustrative messages. And Professor, we have Professor Ayman Rifai with us till late night, and he will comment.
Thank you, Professor Yasser. First, let me thank and congratulate Professor Wesam and Professor Ahmed for this very interesting and informative presentation. Actually, it was elegantly presented in a very smart way as usual. The presentation is full of valuable messages, actually, about one of the challenging and silly glomerular lesions that we are facing every day in our clinical practice, focal segmental glomerulosclerosis. But I want to stress on one important message, that we are facing a lot of steroid-resistant nephrotic syndrome cases, and most of them are focal segmental glomerulosclerosis. So I think we should go further and increasing the scale of using one of the missing aspects in our approach practice, which is the genetic studies. We should increase our practice and asking for genetic studies in such patients. There are lots of studies that show that there is mutations in certain genes, especially the NBHS1 and 2. And I think if with the help of these positive genes, we can get a lot of benefits. Among them is weaning of unnecessary immunosuppression, and just the RAS blockade may be sufficient. Number two, avoiding unnecessary rebiopsies. And I think also number three is this will affect the decision of transplantation. We may deprive patients focal segmental from transplantation fearing of recurrence. So I think we should ask for genetic studies more frequent than we do before going to sophisticated and expensive immunosuppression. Usually this patient receives steroid, then cyclosporin, MMF, and then rituximab. I think before going for rituximab or any further expensive and hazardous immunosuppression, we should go for genetic studies. I may argue with Professor Ahmed for the value of prophylaxis plasmapheresis prior to transplantation in primary focal segmental patients in order to prevent recurrence. I think there are two recent studies that showed clearly that the recurrence rate was significantly less. It was, I think, 30% for patients who received pre-transplant plasmapheresis versus 60%. So I think doing prophylaxis plasmapheresis prior to transplantation is still have place. Thank you very much. I really enjoyed this presentation and these clear and valuable messages. Thank you, Professor Wesam. Thank you, Professor Ahmed. Thank you, Professor Yasser.
Thank you, Professor Ayman. Let me ask you a question. Is it easy to do?
Dr. Yasser, if I would comment just in 2 words, Dr. Ayman, thanks a lot for your valuable comments. Regarding the genetic part, inshallah, we'll mention the treatment if possible in any next session. But the issue with the genetic, because I've already asked about this, we have more than 50 culprit gene that we need to centers around the world that do the screening. Even in the States, they don't do the screening for the genetic, for the culprit genetic lesion because they don't know where to be done. So it's very few centers that do the gene screening for this type. Regarding the plasmapheresis, the issue is it gives like 2 months of freedom from the recurrence of nephrotic syndrome, but then it recur again. And this was the last critical appraisal for the article of doing a prophylactic plasmapheresis. Actually, it was like 106 patients, and they said that this data was not consistent to be, persistent effect. It was just delaying the recurrence to 2 or 3 months after the transplant. Thank you.
Thank you. And it is not easy to do. I failed really to do genetic testing for FSGS here in Egypt. I am asking about your experience. If anyone can do it easily.
It's even difficult in the States. I've actually asked it in Cleveland Clinic. They don't do it. They have to send it to special centers.
Thank you for this nice session, and I am to apologize to Dr. Sabah Al-Parasi. She asked a question about the role of plasma exchange in treatment of FSGS, and as I have mentioned, we will have a specific session in this series about the treatment of FSGS as it deserves, and it is a very hot topic, and that needs a separate session. Thank you, Professor Wesam. Thank you, Professor Ahmed, for this heavy, exhausting, and too informative session. Lot of messages, to the point message. Clearly how to interpret biopsies, how to add this to our clinical experience. Thank you, Professor Ayman, for being with us till this late night. And thank you all to be with us in the whole session, starting from the start and to this last late night, all audiences and attendances. Excuse me to close and meet you in the next session, which will be by Professor Mona Roshdi about the perioperative management of renal patient, will be next Wednesday. And meet you again and in this series about the next treatment of FSGS, which will catch single session. Thank you, Professor Ahmed. Thank you, Professor Wesam.
Thank you very much.
Thank you for everyone. Thank you for everyone.
Thank you for everyone. Thank you, Ahmed.
Thank you very much. Thank you.
Good night.
صباح الخير. صباح الخير.
وعليكم السلام ورحمة الله
Excuse me to close the session. Thank you for all audiences.
السلام عليكم.
وعليكم السلام ورحمة الله.
عليكم السلام ورحمة الله.